Hello everybody and welcome to Nitrous Oxide training. I'm Dr. Varela and what we will be doing today is we will be doing a series of videos that will give you an understanding of nitrous oxide, the science behind nitrous oxide, and also how to use it. It's really important that you very carefully listen to each one of these videos because they will form an integral knowledge base that will allow you to not only safely administer nitrous oxide in the clinic, but also allow you to be able to pass the exam that will actually be a requirement before you can um, start using nitrous oxide in the clinic. So there will be really four components to your nitrous oxide education here at the dental school. The first will be this series of videos. The second will be an exam or evaluation on your knowledge of that is presented in these videos. The third is your nitrous oxide experience in the clinic, which to be able to start using nitrous oxide in the clinic to gain experience, you'll have to pass the exam. And then the fourth aspect of it will be a competency exam um, for nitrous oxide. Now, it's really important that you understand that nitrous oxide, just like any other sedative methodology, can actually lead to any level of sedation on the sedation spectrum. So what that means is that if you think that nitrous oxide can't put somebody into general anesthesia, then you're wrong. Because nitrous oxide at very high levels can actually cause somebody to go into general anesthesia. And what I mean by general anesthesia is that that you can't arouse them awake. They lose their ability to be able to breathe on their own. They lose a lot of protective functions like coughing or swallowing, and really you put the patient in such a dangerous situation that the patient could go hypoxic into respiratory arrest and die. So please understand that we expect you to operate under the highest level of academic honesty and professionalism because this is so incredibly important that each individual understand what nitrous oxide is, the science behind it, and how to do it carefully. And so when you are evaluated, you will be doing this individually, and we'll probably have you all come together as a group in, let's say, your clinical challenges course to be able to take the examination. You will be taking it individually, but we'll have you all take it at the same time during clinical challenges. So let's go ahead and get started. So nitrous oxide is an inhaled anesthetic, which basically means that its uptake into the circulation occurs at the alveoli through gas exchange. There's two different types of inhaled anesthetics. The first type is known as volatile anesthetics. Now these have a low vapor pressure and high boiling point, which basically means that they exist as a liquid at room temperature and atmospheric pressure. Now, because they exist as liquids at room temperature, they have to be vaporized or put into a gaseous form in order to be inhalable. Now you can see in these pictures on the screen what those vaporizers look like. And if you ever get the chance to do dentistry in an operating room, you'll be able to see some of this vaporizing equipment alongside all the other anesthesia equipment. Now, the second class of inhaled anesthetics are gaseous anesthetics. Now, these have a high vapor pressure and low boiling point, which makes them exist as gases at room temperature. Now, as gaseous anesthetics are really important, particularly to dentistry, because nitrous oxide happens to be a gaseous anesthetic. Now, you all remember my class during the summer of your first year, the local anesthesia course, and how we talked about the way that these local anesthetics are taken up into the body, distributed, metabolized, and eliminated. And inhaled anesthetics work very differently. Their uptake, distribution, and elimination occur at a much faster rate than local anesthetics that are injected. Now, this is actually a benefit because we want our inhalable anesthetics to have a relatively quick onset and termination. And for this to occur, the concentration in the target organ has to fluctuate pretty rapidly. Now, the target organ in our case is the CNS, or the brain. And there are several factors that determine how quickly the levels in the CNS change. The first is inspired concentration. The concentration of a gas in the alveoli is what drives the uptake of the drug into the body. Now, the alveolar concentration can be changed by either changing the concentration of the gas introduced into the lungs or changing the volume of gas that ventilates through the alveoli. The other two things that affect this are solubility and cardiac output. Now, a gas's solubility in blood will impact its uptake, right? We measure a gas's affinity for blood compared to normal gases in the air that are inhaled. And this measurement is assigned a number, and this number is known as a gas's partition coefficient. Now, the last factor that controls uptake is cardiac output. An increase in cardiac output will increase pulmonary blood flow. That makes sense, right? Heart beats more, then more blood is actually going in through the lungs. This will also then increase the uptake of the gas into the blood. Now, the blood flow through the CNS is really tightly regulated, so an increase in uptake of the anesthetic gas into the blood may not necessarily translate into an increase in the CNS concentration of the gas. So as such, the gas will be distributed more widely throughout the body, but not necessarily through the CNS. Now, the alveolus is essentially a pocket of air surrounded by a thin membrane that contains capillaries. And the gases within the alveoli are separated from the capillaries by 1 to 2 millimeters of tissue known as the alveolar epithelium. Now, gases diffuse according to their partial pressures. Oxygen within the alveolus is 103 millimeters of mercury, whereas within the pulmonary capillaries, it's only 40 millimeters of mercury. Now, oxygen is therefore forced into the capillary from the alveolus. Now, the same principles apply to nitrous oxide. As the blood becomes saturated with nitrous oxide, the rate of diffusion into the circulation decreases. When nitrous oxide is turned off, the reverse process occurs, thus eliminating the nitrous oxide from the blood. And this is really talking about this concept of partial pressures is really just talking about this overall concept of concentration gradients, if you remember how concentration gradients can kind of affect the movement of molecules. And in this case, this partial pressure conversation is really kind of setting us up to understand how the movement of gases is affected by the partial pressure on one side of the alveolar epithelium as opposed to the other. Now, nitrous oxide is relatively insoluble in the blood, which means that it does not combine with any blood elements. And additionally, nitrous oxide is not metabolized in the body at all. So now we'll continue our discussion of the pharmacology of nitrous oxide with a comparison of its onset with other routes of administration. Now here we have the oral, rectal, IM is intramuscular, IV is intravenous, and inhalation is inhalation, right? So you'll notice that the IV and inhalation routes of administration have relatively fast circulation times, and it's equal to or less than 20 seconds respectively. This means that the gas will enter the systemic circulation very, very quickly, and then it takes about 2 to 3 minutes for the onset of clinical actions to develop. Now, that clinical action peaks for inhalants after about 3 to 5 minutes, whereas it peaks for other different routes at different times. You see, IV anesthetics are 60 seconds, and intramuscular is 30 minutes, rectal is 60 minutes, and oral is 60 minutes. Now, you'll notice that the depth of sedation is difficult to change with enteral and some parenteral routes of administration. And you might ask yourself, why is that? Well, a change in the level of sedation is highly dependent on a patient's individual response to the drug, which is really deeply rooted in the pharmacokinetics of the drug. And we talked a little bit about this as it relates to local anesthetic drugs in your local anesthesia course. Now, with oral, rectal, intramuscular, and intranasal routes of administration, the time it takes for the drug to be absorbed into the blood and metabolized is difficult to predict because each patient really reacts differently, which is why one person may feel the clinical effects of a sedative drug like Xanax much quicker than another. This makes it very difficult for us to titrate the levels of anesthetic drug to a specific clinical action. So it really becomes difficult to change the depth of sedation because we're essentially trying to hit a moving target. Now, IV, on the other hand, gives us direct delivery of the drug into the bloodstream, which really eliminates that unknown factor. Now, the drug really immediately undergoes biotransformation, and the clinical action of the drug can quickly be observed. Now, this allows us to be able to change the depth of sedation very easily with IV drugs, but it really only occurs in one direction. And we can deepen sedation really easily, but lowering the level of sedation is really a lot more tricky because its elimination is harder to predict between patients. Inhalants, on the other hand, are really easy to manipulate because for the most part, their presence in the body is mediated by constantly introducing them. In other words, that these inhalant gases are not going to be in the body unless you're introducing them. And so if you increase their introduction, then they'll be in the body presumably in higher concentrations. And if you decrease their introduction, then presumably if that goes to zero, they will essentially eliminate themselves from the body because there's not anything that's actually introducing them back in. So the gases are there as long as they're being administered. Now, once the administration stops, as I said, the gases are really quickly eliminated from the body. Now, this particular issue is what helps to determine the duration of action. Because gases have a really quick uptake and elimination, control of the duration of action is really kind of dependent on the provider. So in other words, if you want the nitrous oxide effect to last longer, then you will administer it for a longer period of time. So conversely, the thing that can occur is that if you want it to be shortened, the duration of action to be shortened, then this is accomplished by administering the gas for a shorter period of time. This means one really important thing, that the patient has a really rapid recovery period. Now, if you think about people who go into the hospital and they have IV sedatives, their recovery really is dependent upon how quickly the body can eliminate those agents from the blood. And as long as they're eliminated from the blood, then all those other highly perfused organs don't have access to them. On the other hand, with inhaled anesthetics such as nitrous oxide, the recovery period is really quick, okay? Because as soon as you stop administering this nitrous oxide gas, then the gas is essentially eliminated from the body because it's not being reintroduced. And because it's not being metabolized, it doesn't really stick around in the body. So that's why you'll notice that when classmates that are D4s use nitrous oxide and they put the patient on 100% oxygen for 5 minutes, that's to allow for the gas to be completely eliminated from the body. And then you know that as soon as those 5 minutes are up, the patient is essentially back to the way they were before they were administered nitrous oxide. So the recovery time is really one of the biggest benefits of using nitrous oxide as opposed to other different types of sedation technique. So let's delve into this concept of administering 100% oxygen for 5 minutes. Why do we do that? Why do we administer 100% oxygen for 5 minutes? Well, if a patient breathes room air at the conclusion of nitrous oxide sedation, the gas rushes out of the lungs. More CO2 is removed from the blood than normal, and that lowers the CO2 tension in the blood. Now, as you may know, the presence of CO2 in our blood actually is what triggers the respiratory drive, and that is the drive that makes you want to breathe. And removal of the CO2 from the blood also removes that drive, and that actually depresses respiration. So if you don't have that CO2 drive, then you don't have that presence of CO2 in your blood, then you won't have that respiratory drive, and then you have respiratory depression. Now, what results is hypoxia, which produces a headache, nausea, and having the patient feel lethargic. Now, this situation is known as diffusion hypoxia, and it's really essentially a hangover effect of nitrous oxide sedation or nitrous oxide use. And this only occurs when you don't do the 100% oxygen for 5 minutes at the termination of the procedure. Now, this situation is prevented by having the patient breathe 100% oxygen for 5 minutes at the end of the procedure. So basically what happens is you have the patient on nitrous oxide, let's just throw a number out, 25% nitrous oxide, and let's say that they're on there for 30 minutes, you're ready to be done with the procedure, and so you switch them from 25% nitrous oxide down to 0, and they'll be at 0% nitrous oxide, which means that you'll have 100% oxygen for 5 minutes. And those 5 minutes will help to drive the rest of that gas, the nitrous oxide gas, from the body. And we do that in order to avoid this hangover effect or this diffusion hypoxia, which essentially removes too much CO2 from the blood, thus eliminating that respiratory drive. And then what results is respiratory depression and hypoxia, and that causes these things that we've been talking about, the headache, the nausea, and the lethargy. Now, as I mentioned before, nitrous oxide administration is titratable, which means that you can very easily change its levels in the body. Now, this ability to titrate represents the greatest safety feature sedation technique can really possess, because it really allows the drug administrator virtually absolute control over the actions of the drug. And nitrous oxide sedation really carries some really important advantages. It can be discharged, the patient can be discharged from the office following a procedure without really any limitations on activities. You don't require any injections to administer the nitrous oxide or to reverse it. There's really very few side effects. There's no adverse effects on the liver or the kidneys or the brain or the cardiovascular or respiratory systems. And remember, this nitrous oxide is not being metabolized, so the liver's not going to have anything to do with it. And it's eliminated through the respiratory system, so the kidneys are not going to have anything to do with it. And its exposure to the brain really is dependent on its continual exposure into the lungs. And so its time in the brain or the central nervous system is really limited. depending on how long it's administered. So, and then it can also be used instead of local anesthetics in certain procedures because it has analgesic properties. Some of the disadvantages are the initial cost of the equipment. So if you're building out your office and you're wanting to put nitrous oxide equipment in there, it can be pretty expensive to fit your office with nitrous oxide. You also have that continuing cost of purchasing the gas, both oxygen and nitrous oxide. And the equipment really occupies a really considerable amount of space in your office. Nitrous oxide really isn't a potent agent, and failures do occur. Another disadvantage is that really it requires the patient's cooperation. So basically, just like the next one says, must be able to inhale gases through the nose. For example, nitrous oxide is really great for kids unless the kids breathe through their mouth. And if they breathe through their mouth, they're not getting the nitrous oxide through their nose. And the other thing is for patients who have maybe some problems with breathing through their nose, they're going to have a really hard time getting any kind of benefit from nitrous oxide. Now, it's really critical that you understand that people who are in your office who administrate nitrous oxide have to receive training for it. They have to be trained. That means that your assistants or anyone else who will be present in the room that works for you, that will be helping you with the patient that is being administered nitrous oxide, has to receive training. They have to be trained. If they're not, they technically really shouldn't be in the room with you, or the patient should not be left alone in the room while nitrous oxide is being administered with untrained persons. The last disadvantage is that there are some trace amounts of nitrous oxide that can be deleterious, and these are unscavenged traces of nitrous oxide. So we'll talk a little bit about what unscavenged means. And this really comes into effect when we talk about nitrous oxide's deleterious effects with pregnant patients and pregnant women in general. So the indications for nitrous oxide sedation really have to do with three different types of groups. First are people who have high dental anxiety or a lot of fear of the procedures that will be taking place. Second is the medically compromised patient, and we'll talk about that. And third is the patient that has a really strong gag reflex. So this will be the end of this first video. We will come back with the next slide and jump right back in to the indications for nitrous oxide sedation. Thank you.